Development Director for the Oley Foundation. Most of you are probably familiar with the Oley Foundation, but just in case this is your first experience, I'd like to briefly introduce the organization. The Oley Foundation strives to enrich the lives of those living with home nutrition support, both intravenous nutrition, sometimes called HPN or TPN, and tube feeding. We do this through education, outreach, and networking. The Oley Foundation was founded in 1983 by Dr. Lynn Howard and her patient, Clarence Oley Oldenburg. Today, we serve approximately 17,000 members. All of our programs are free of charge for patients and their families. First, I'd like to go through a few housekeeping details. You should see a toolbar on the right side of your screen. Click on the orange arrow to show the control panel if you haven't done so already. In the questions section, you can type in any questions you have for myself or for the presenters. Please note we will not be responding to the hand-raising function in the control panel. We will answer as many of the questions as possible during the questions and answers period at the end of the presentation. We'll post a recording of the presentation and the handouts after the webinar on the Oley website. In the bottom of the panel, you should also see a section that says handouts, and those are the slides from today's presentation in case you want to print those out and follow along. Note also that we have muted all the participants, so you don't need to worry if there's background noise wherever you are taking this webinar. And finally, if you're having technical issues, please go to the web address that's in the center of the screen right now. It begins with help.citrix.com/webinar/join. Now for our presentation. Short bowel syndrome can have severe effects on absorption, overall health, and quality of life, but many of the symptoms can be minimized with the use of diet modification, hydration techniques, as well as medical and surgical treatments. Today's webinar will cover the etiology of short bowel syndrome, metabolic effects, and methods to treat. It gives me great pleasure to introduce today's presenters, Dr. Doug Seidner and Dr. Laura Matarese. Dr. Seidner is an Associate Professor of Medicine in the Division of Gastroenterology, Hepatology, and Nutrition at Vanderbilt University Medical Center. He serves there as the Director of the Center for Human Nutrition. He obtained his medical degree at Upstate Medical Center in Syracuse in 1983 and went on to complete a residency in medicine, followed by a fellowship in nutrition and metabolism at New England Deaconess Harvard Medical School. He subsequently completed a fellowship in gastroenterology at George Washington University School of Medicine and Healthcare Sciences. He is recognized as a fellow in the American College of Gastroenterology, American College of Gastroenterology, and the American Society for Parenteral and Enteral Nutrition. He has served on various committees in the American Society for Parenteral and Enteral Nutrition and the American Society for Nutrition, and has served on the board of the Oley Foundation. His research interests include improvement of clinical outcomes in patients on home nutritional therapies and intestinal rehabilitation for severe intestinal malabsorption. We are also joined today by Dr. Laura Matarese. Dr. Matarese is a professor in the Division of Gastroenterology, Hepatology, and Nutrition in the Brody School of Medicine at East Carolina University in Greenville, North Carolina. She is the author of over 240 publications, including books, chapters, manuscripts, abstracts, and videos, and currently serves on the editorial boards of several journals. She has lectured extensively, both nationally and internationally, and has held numerous positions within the American Society for Parenteral and Enteral Nutrition, the Academy of Nutrition and Dietetics, and the Commission on Dietetic Registration. Dr. Matarese has served as the past president of the National Board of Nutrition Support Certification and as a member of the Board of Trustees of the Oley Foundation. She is the recipient of numerous honors and awards, including the American Dietetic Association Medallion Award. We are thankful to have both of you presenting today. Dr. Matarese, I will turn over the presentation to you now.
All right. Hello, everybody, and thank you, Roz, for that very kind introduction. It really is an honor and a privilege for me to be here today to discuss a topic that I absolutely love and to share the virtual podium with Dr. Seidner. I have a few disclosures which are listed here, but everything I'm presenting is evidence-based. So the learning objectives, at the end of my presentation, the goal will be to describe the physiological consequences of short bowel syndrome, explain the functional changes that are associated with intestinal adaptation in SBS, and to describe the dietary strategies for reducing dependence on parenteral nutrition. Just to sort of set the stage a little bit, short bowel syndrome is the most common form of intestinal failure. And as many of you know, it's a really debilitating disorder, and it's a very complex disorder. It's associated with loss of portions of the bowel, or sometimes it's just loss of intestinal function. Typically, it follows extensive surgical resection of the intestine, and that may be due to disease, trauma, or sometimes congenital defects. The bottom line is that it results in your inability to maintain fluid, electrolyte, and nutrient balances. The possible causes for a surgical resection will vary. Often it's as a result of vascular catastrophes such as embolus or thrombus, where the blood supply is cut off to the bowel, complications of bariatric surgery, trauma, malignancy, radiation enteritis, which really results in a functional disorder, a volvulus or strangulation of the bowel, hernias, fistulas, and Crohn's disease. But for whatever reason you have short bowel syndrome, the bottom line is it may result in malabsorption. Although I've never seen two short bowel patients who are exactly alike, on this slide you see some differences, general differences. If the surgeon had to remove most of the small bowel, or most of the bowel and all of the colon, and you have an ostomy, an end jejunostomy, that is considered type 1. And people in this category get dehydrated very quickly, and you will often hear them say, whatever I eat comes right out. Type 2 is the jejunal colic anastomosis. In other words, you still have some of your colon and your jejunum, and it's hooked together. And these people really can do quite well, especially as the bowel adapts. And then the jejunal ileal anastomosis, which is type 3, in which part of the ileum is still present, these patients seem to do the best. The only reason why I present this is because I think it's important that you understand your GI anatomy, because the diet is really based on the anatomy. Now, in my opinion, I think that diet really forms the foundation of therapy. And the nutrition prescription has to be based on your remnant GI anatomy. And it is, in fact, the most potent stimulus to intestinal adaptation. So the worst thing you can do is just make somebody NPO. We want people to eat, but you have to eat the right things. So on this slide, you see the differences in the diet prescription based on the GI anatomy. In other words, whether the colon is present or whether the colon is absent. So for all patients, the carbohydrate, we really restrict simple sugars. The protein has to be a fair amount, 20 to 30% of the calories. But if you notice, fat is not really restricted except if the colon is in circuit. And then it's not totally fat-free. We're saying you just have to limit the fat to about 20 to 30% of your calories. The fluids should be isotonic fluids or hypoosmolar fluids. So in both cases, we want to try and avoid the consumption of really hypertonic things like soda pop and things like that, and I'll discuss that in more detail. Soluble fiber, if you can get that through your diet, that's the best thing. It works extremely well for patients who have a colon in circuit, but sometimes we use soluble fiber just to sort of thicken up the ostomy effluent. Oxalates are limited if you have a colon in circuit to prevent the formation of oxalate stones. And in each case, the meals should be small, frequent meals. Now, what is a simple carbohydrate and what is a complex carbohydrate? The things you need to limit are the simple carbohydrates like sugar, candy, cakes, cookies, pies, regular soda pop, jelly, jam, syrup, ice cream, sherbet, sorbet. These things, when you consume them, the sugar particles are so small and water rushes into the bowel to try and dilute it, and that's when you get a lot of diarrhea or increased ostomy effluent. But there are good carbohydrates, things like pasta, potato, bread, cereals, whole grains as tolerated, and fruits and vegetables as tolerated. These are much larger carbohydrate molecules and generally better tolerated by somebody with short bowel. So it's the type of food, but also the way the food is consumed that affects absorption. So here you see two diets that provide 2,400 calories, 50% carbohydrate, 20% protein, 30% fat. On the left side of your screen is the way somebody with short bowel syndrome should be eating. On the right side is the way you should not eat. So notice on the left side there is breakfast and a morning snack, and that will be much better tolerated than a diet on the right side, which just has orange juice and a cheese and fruit-filled Danish. So the actual load of food is too large on the breakfast on the right side, and it has too much sugar and too much fat. Same thing with lunch. And you can see you get plenty of food on the left side of the screen, but you will tolerate that more than somebody who has a piece of pizza or soda pop on the right side of the screen. And then dinner and an evening snack. Again, you notice there's small frequent meals. There isn't a lot of simple sugar. So these are really much better tolerated. Now, fluids are a very important part of your diet prescription, and many of you are on these special oral rehydration solutions. And these take advantage of the sodium-glucose co-transport system. So the glucose, or the sugar, and the sodium have to be in a certain concentration in order to enhance absorption. And here on this slide, you can see that the best absorption is really when the sodium is at 120 millimoles per liter. But that's pretty salty, and most people cannot tolerate that. But you get reasonable absorption, pretty good absorption, in fact, when the sodium is around 90 millimoles or 90 milliequivalents. Now, there are a lot of oral rehydration solutions on the market, and so I just list a few of these on the screen in front of you. The World Health Organization standard formula, that was one of the original ones with 20 grams of carbohydrate and that 90 milliequivalents of sodium. They have a reduced osmolality formula and various other solutions that are listed on your screen. The one thing I did want to point out is that Gatorade or most sports drinks are not a good choice for you. If you notice, they have a lot of carbohydrate and not much sodium. You could take something like Gatorade 2, the G2, which has less sugar, and add some salt to make it a little bit more appropriate. Now, there are other things. Sometimes your healthcare providers will give you a prescription for an oral rehydration solution, and this is an example of two of the solutions we used when I was at the University of Pittsburgh. Here's another very popular recipe for an oral rehydration solution that you can make with ingredients from your kitchen for a mere few cents. It's very inexpensive to do. There are other things you can do. You can take fluids like Gatorade and add water and salt, or fruit juices and add a certain amount of water and salt to create a solution that would better meet your needs. And then I also wanted to comment just briefly about oral supplements. Although the focus of my presentation is diet, as most of you know, as you try and wean yourself off parenteral nutrition, or you're trying to minimize the parenteral nutrition, you will have to take additional vitamins and minerals. And your healthcare provider more than likely will measure these and tell you exactly how much you need to take. And then, although we talk primarily about diet, I also wanted to mention that sometimes we use enteral nutrition in addition to diet. And here you see this one study which was done in Paris. They took some short bowel patients and then they gave them a combination of just oral feeding, enteral tube feeding, or a combination of oral and enteral. And you can see that the absorption of calories, lipid, protein, and carbohydrate was actually much better when they used a combination of oral and enteral feedings. So that is another option. So I've provided you with a few references in case you wish to read further. And the summary of my part of the presentation is listed here. And I think there are a variety of techniques that are available to treat intestinal failure, including diet, medications, hormonal therapy, surgical reconstruction, and transplant. But the goal is always to restore intestinal health in the safest, most efficacious manner consistent with the patient's lifestyle and wishes. And finally, I truly believe that diet is the foundation of therapy. So I thank you for your kind attention, and now Dr. Seidner will begin his presentation.
Good afternoon. Can everybody hear me? Just want to make sure, Rosalind, I'm on the air.
Yep, and you're doing well, Doug.
Okay. Well, Laura has set the stage for my part of the discussion. I too would like to thank the Oley Foundation for giving the opportunity to make this presentation to all of you, and for the very kind introduction that Rosalind provided. The title of my presentation is The Medical and Surgical Treatments for Short Bowel Syndrome. These are my disclosures. For those of you who may or may not be familiar with some of these companies, Shire is the manufacturer of Teduglutide, which I'll talk about in a little bit later today. And Zealand is a manufacturer of a GLP-2 analog that is currently undergoing clinical trials. My comments will all be evidence-based, and I will also discuss off-label uses of medication, and will specifically note those through my presentation. These are the main objectives of my presentation today. I will start by reviewing some key concepts in understanding the treatment of short bowel syndrome. Then I'd like to discuss the indications, mechanisms of action, and the side effects of the medications that are used for this condition. And then finally close by having a brief discussion on the role of surgery for individuals with short bowel syndrome. So my first concept is to discuss the goals of care. These were touched upon by Laura. The management of these patients is to try to obtain enteral autonomy as best as we can. The treatments which we discussed is often referred to, or that we're discussing today, is often referred to as intestinal rehabilitation. That includes diet modification, enteral supplementation, medications, and intestinal trophic factors, along with surgery when that's appropriate to do. I want to point out that how this all comes into play for your particular situation depends on when you had bowel resection and then how long you've been on parenteral nutrition. As you can see in this figure, bowel transplant is way down to the right with the dotted line, and it's something that we don't do that often. Enteral autonomy is just one of several objectives. I'd like to emphasize that it is very important that the goal of these programs and processes is to make sure that any nutritional deficiencies are repleted and that your nutritional status is well maintained so that you feel well, that you're controlling your diarrhea as best as possible, and maintaining good hydration. If you're on parenteral nutrition, we want to do our best to prevent complications associated with this therapy, and the overall goal is to optimize one's quality of life. The second concept I'd like to go over is just defining what short bowel syndrome is. So this is a condition that leads to severe intestinal malabsorption that occurs after extensive small bowel resection. The features include diarrhea, dehydration, electrolyte abnormalities, and malnutrition. Now this cartoon shows normal intestinal anatomy. I want to point out to everybody that here we are in metric units, centimeters, and most of us think in terms of inches and feet. Well, the duodenum is actually a term, an anatomic term, which means 12 inches. So it's a way to remind us that 30 centimeters is 12 inches or 1 foot. So you can see that a normal small bowel length ranges from approximately 10 to 20 feet, depending on in an adult, depending on the size of the adult. That following the duodenum is the jejunum, where most of our nutrients are absorbed, and then followed by the ileum, and finally the colon, which is approximately 5 feet in length. So short bowel syndrome is defined as having less than 200 centimeters, that's about 7 feet, beyond the junction of the duodenum and the jejunum, often referred to as the ligament of Treitz. So that's 200 centimeters of remaining small bowel, any combination of the jejunum and ileum. So strictly speaking, short bowel syndrome is less than 200 centimeters of jejunum and ileum. Next, the physiologic changes that are responsible for malabsorption is illustrated in this cartoon from the AGA. It shows many of the major conditions that occur as a result of short bowel syndrome that interfere with your ability to absorb your nutrients. The first is acid hypersecretion by the stomach. The next is rapid transit through the remaining small bowel. There's obviously loss of intestinal surface area, because by definition that is the short bowel syndrome. This cartoon also shows impaired residual bowel, or that means underlying bowel disease. So for example, patients with short bowel may get to that point because of underlying Crohn's disease. So it's important to make sure that the activity of Crohn's disease is not active, that it's quiet, that it's being treated appropriately with medications if the disease is active. And I won't talk about these medications for the treatment of Crohn's disease because it's a completely different topic, but it may be an important issue for some of those in the audience. Next, there's bacterial overgrowth, which results from resection of the valve between the small bowel and the colon, the ileocecal valve. And then lastly, there's bile salt loss or bile acid wasting. Bile acids are involved in emulsifying the fat in your diet so that the pancreatic enzymes can best digest them and you can absorb fat in your diet. So these are the factors that we consider when when using medication to treat this condition. So the first group of medications to discuss are those that affect gastric acid hypersecretion. This happens commonly after extensive small bowel resection. It tends to be relatively short-lived process, lasting anywhere from 4 to 6 months. And one of the mechanisms involved in causing this acid hypersecretion is an excess secretion of an intestinal hormone called gastrin. So there's hypergastrinemia. Emia just means in the bloodstream. So hypergastrinemia is excess gastrin in the bloodstream. Because of excess acid, individuals can develop peptic ulceration. Excess acid will inactivate pancreatic enzymes, which are the main digestive enzymes that the digestion that occurs within the lumen of the bowel. It can precipitate bile salts, so the ones that you got left may not be functional, and it can result in these metabolic abnormalities, alkalosis and a low potassium. The first class of medications to treat gastric hypersecretion are proton pump inhibitors. Here are the names of all of the products that are currently on the market. They all work reasonably well. Often they have to be taken twice a day, and they do have side effects, unfortunately some of which are similar to those side effects that occur with short bowel syndrome, but fortunately they're relatively uncommon side effects. Another class of medicines are referred to as histamine 2 receptor antagonists. Histamine is one of these internal hormones that directs the stomach to make acid. It was the first group of medicines to work chemically to reduce acid. Before any of these medicines were available, people would have to take antacids that would work on contact within the stomach. So here's a list of the currently available medications. You can see them there. And there's a wide variety of side effects that we have to look out for in individuals who we dispense these medications. These medications, I'll just mention that the histamine 2 receptor antagonist, we will occasionally administer them through parenteral nutrition to make sure that they're absorbed and that they work. Within this category of medicines, a subcategory of sorts, I've included medications that treat GI secretions in general. Not that there's excess secretions elsewhere in the GI tract, but what happens with resection is that you often lose part of the bowel that will absorb the salt and water that's secreted into the bowel to help process your food. So there's a class of medicines known as sandostatin analogs. Octreotide is one of the ones that are available. It's been around for the longest, and it inhibits a host of hormones and decreases GI secretions. We tend to use this medication in individuals who have what we term as a high output jejunostomy, where an individual is putting out liters of fluid from their jejunum and developing dehydration. There's been studies that have shown that this therapy is effective in this condition. The reason why we don't jump to this medication right away is that it can interfere with intestinal adaptation by shutting off many of the hormones that are involved in promoting intestinal adaptation after resection. I've listed here some of the side effects that you can read. Another medication that, so octreotide is not used terribly often in this condition, except for individuals with high output jejunostomies and sometimes individuals with excessive diarrhea that is not controlled by antidiarrheal medications, which we'll talk about in a moment. Another medication is clonidine. This falls in the category of alpha-2 adrenergic receptor agonist. It's a medication that is typically used to treat high blood pressure. So you can see here that one of the side effects is low blood pressure or hypotension. So interestingly, taking this medication can decrease intestinal secretions and help control diarrhea And on occasion, we will use this medication to help individuals control their diarrhea. Both of these both of these medications are not specifically labeled for short bowel syndrome diarrhea, so they're both considered off-label or not FDA approved. The next physiologic change that occurs in short bowel syndrome is rapid gastrointestinal transit. The transit time of food out of the stomach through the digestive tract is very short. And as I mentioned before, that interferes with the contact time and absorption of food. And so things that we can do to slow this down can help improve absorption and control symptoms. So it generally occurs after the more distal segments of the bowel are resected. One of the key hormones that is produced by the distal bowel is something called peptide YY or PYY. The levels of this hormone are diminished, and that's believed to be one of the main drivers of rapid transit through the intestinal tract. Also, GLP-1, GLP-2, that is glucagon-like peptide 1 and 2, also affect transit through the bowel, as do several other factors. There's also an effect of resection of the ileocecal valve in affecting transit time as well. So the consequences of this are, as I've already mentioned, rapid gastric emptying, decreased intestinal transit time. There's also an increase in gastric secretions from a disturbance of these hormones, in addition to hypergastronemia, which I've mentioned. So here's a list of the medications that are used as antidiarrheal medications. Those of you who are familiar with these meds recognize that these are all narcotics. They interact with receptors within the intestinal tract. There are specific opioid receptors, and when you interact in a certain way with these compounds, you will slow down the motility of the bowel. I'm showing you, illustrating here in the table, some of the dose ranges that are used for these medications. We usually go in a stepwise fashion when we dispense them. The first one, loperamide, is a synthetic narcotic that does not cross the blood-brain barrier or get into the brain, so it tends not to cause cognitive impairment potentially as much as the others. So we often use this as a first medication when we're trying to control diarrhea. We will sometimes add medicines, or we will sometimes go in a stepwise from loperamide up to codeine and then tincture of opium to treat the diarrhea. These medications tend to be most effective if they're given before meals. Generally, about a half an hour before is best. Some of the side effects. The first bullet point, those are attributed to excessive amount of medications, where you actually create a chemical partial bowel obstruction, so you can get pain and distension and nausea and vomiting. And what you do in that instance is you just back down on the amount of medication that you're taking, or even stop it to let it get out of your system, and then resume these meds at a lower amount. We talked about the central nervous system effects of these drugs, sedation and dizziness, and then specifically for Lomodal, which is a trade name, it's a combination medicine, diphenoxylate and atropine. The atropine that's added to diphenoxylate is to discourage abuse of the medicine, and a side effect of these anticholinergic medicine is dry mouth, xerostomia, rapid heart rate, or dilated pupils. The next physiologic condition to discuss is small intestinal bacterial overgrowth. This complication is generally uncommon unless you've got a loop of bowel that's out of continuity, referred to as a blind loop, or a stricture where motility is impaired, or even an internal fistula where bacteria downstream can get up into more proximal bowel, and you get excess bacteria in the proximal digestive tract, and it interferes with your with your ability to absorb those nutrients, because they're, in a sense, competing for the same nutrients. Normally, there's a lot of bacteria and other microbes in the colon, whereas in the small bowel the levels are modestly low. But with intestinal resection, you can get this small intestinal bacterial overgrowth where the bacteria migrates upstream and, as I said, competes for your food. So conditions that lead to increased intestinal transit is also a risk factor for this condition. So there's some patients who have poor motility because of multiple surgeries in the past, or there's a rare condition called intestinal pseudoobstruction, which is at risk for developing this condition. If you decrease gastric acid or have pancreatic insufficiency, you could be prone to this, to small intestinal bacterial overgrowth, because the acid and pancreatic secretions help decrease the bacterial load in the upper tract to a lower level. And then finally, and as I've already mentioned, the ileocecal valve plays a role in keeping the bacteria, typically in greater amounts in the colon, from refluxing back up into the small bowel. These are the consequences of having bacterial overgrowth. They compete for your luminal nutrients. They can actually cause some inflammation of the lining or mucosal injury. And then a relatively unusual condition, if these bacteria happen to make something called a D-lactic acid, you can get D-lactic acidosis, which tends to interfere with thought processing, and it's something that we occasionally consider if we see somebody with a blood work, a basic metabolic panel with a low bicarbonate, which shows that they're acidotic. So these are just some of the consequences of small intestinal bacterial overgrowth. So the treatment is surgery if there's a stricture or narrowing or bowel out of circuit. You can occasionally need to limit antisecretory or antidiarrheal medications to help find a good balance between the positive effect of these medications and the development of small intestinal bacterial overgrowth. Probiotics have been tried. They have generally not been shown from clinical investigations to be beneficial, but those of us who care for individuals with short bowel syndrome have come into contact with a host of people who clearly get better when they take these over-the-counter supplements. So I will discuss this with my patients when I'm trying to help control their symptoms. So there's not a lot of evidence to medical literature to support these products, but we know in practice that they are helpful. Then finally, there's antibiotics. I've listed 3 of them for you here. Of a very price range. They're all off-label. These medications are generally approved for treating infections such as pneumonia or abscesses. With rifaximin, it's a medicine that's approved for the treatment of C. difficile colitis, for example, but not specifically small intestinal bacterial overgrowth. So all these antibiotics, which we commonly use to treat this condition, are all considered off-label. They can be variably effective, so sometimes you need to try one, and if you get if you don't get a positive effect, try another one. Occasionally, we'll have patients who get benefit. They have less bloating and diarrhea when they're on the medicine, but when they stop it, they don't have a durable effect. If you get a durable effect, you just take these medicines as needed. If you stop it and your symptoms come back, we'll usually resume them, and we'll sometimes alternate between 2 or 3 to control symptoms. So there's a wide range of management approaches to using these antibiotics for individuals with small intestinal bacterial overgrowth. Next, I'd like to mention bile acid therapy. Specifically, it's important to understand that normally there's a certain concentration of bile acids within the bowel to help emulsify the fat in your diet. That bile acid makes a cycle and is reused. It's absorbed by the distal 3 feet of the ileum, terminal ileum, 3 feet of the terminal ileum, and you recycle these bile acids several times each day under normal circumstances. If you resect a portion of that 3 feet, you can still maintain your bile acid salt pool or level in the body, but it's not well absorbed by the terminal ileum, and it spills into the colon, and it can cause diarrhea. So there's some individuals who have resection of a portion of the terminal ileum, usually individuals with Crohn's disease, who have diarrhea after surgery, where these 2 products, cholestyramine and cholestyramine, will help. With most patients with short bowel syndrome, on the other hand, they've lost more than 3 feet of small bowel, and these medications tend not to be particularly effective. They do absorb bile salts and vitamins and minerals, and so they can interfere with your nutritional status. And I must say that there's more patients who I've removed this therapy from or stopped these medications than I've started these medications for in managing short bowel syndrome. There is a bile acid that's available in Europe, cholecalciferol, which has been studied and shown to be effective. It's not available in the United States, but this is essentially a bile acid that replaces that diminished pool that individuals with short bowel syndrome have, and it helps them absorb their fat somewhat better, and can be effective in individuals who've tried all those other steps that we've discussed before. Ox bile has been tried over the counter. There's a single case report to support its use. It's not going to be covered by insurance because it's over the counter, and it may not be effective. I have not recommended it in too many patients. There's been varied improvement with its use. Finally, pancreatic enzyme replacement therapy is discussed in the management of short bowel syndrome. There's only 1 report out there showing improvement in a patient. So generally, it's not commonly used, not terribly effective. But having said that, it's very, very safe, generally few side effects, and is something that can be tried after you've done many of the steps that we've previously discussed. I'd like to wrap up this section on medications by reviewing Teduglutide, and which is a glucagon-like peptide 2 analog. GLP-2 is a 33 amino acid long peptide that is cleaved from a molecule that the body makes called pro-glucagon. This is secreted by the distal bowel in what are termed intestinal L cells. So these L cells are located in the ileum and colon, and if you when you eat your meals, this is naturally secreted and helps the bowel work normally. If you resect part of the bowel but still have the distal bowel remaining, this helps your bowel adapt. But often individuals have resection of their ileum and colon and have very low levels of GLP-2. Both of these compounds will stimulate crypt cell proliferation, which is basically fancy medical terminology for growth of the young cells in these lower crypts of the bowel. The lining of the bowel is undulated. It's has tips, villus tips, which is where your nutrients are absorbed, and then between these tips is an area termed the crypt where the new cells are made. So these compounds stimulate crypt cell proliferation. They inhibit cell death, which is enterocyte apoptosis. They help increase the height of the villi by this promotion of growth. It helps increase the number of molecules which help you transport nutrients. It improves blood flow to the intestinal tract, and it also inhibits gastric acid secretion and motility by slowing gastric emptying. The Teduglutide was approved following 2 phase 3 clinical trials. They were both 24 weeks long, done internationally, a randomized, double-blind, placebo-controlled trial, as you can see here, in a total of 100 and 69 adults. The requirement to enter this study is that you needed to be on parenteral support, either IV fluid or parenteral nutrition, for 12 or more months. And the primary endpoint of both of the studies was a reduction of the parenteral support by the end of the 24 weeks. The endpoints were positively met for this particular dose of teduglutide that I illustrate here, this 0.05 grams per kilogram per day. You can see the design of both of these studies. What's termed the 004 study had enrolled patients in a 2 to 1 ratio for these three groups, the 0.5, the 0.1, and then the placebo, respectively. And then this was followed by the STEPS trial, where there was a 1-to-1 distribution of patients either receiving the 0.5 dose or placebo. Because the drug was approved in a relatively few number of patients, the FDA requires the manufacturer to follow what's called a risk evaluation and mitigation strategy. This is to assure that there aren't a higher rate of side effects seen with the long-term use of this drug, and that the benefits continue to outweigh the risks associated with the therapy. These are some of the risks and precautions that go along with prescribing this drug. It is a growth factor. So if you've had a cancer in the last 5 years, this drug is relatively contraindicated. Because it causes intestinal growth, it can cause intestinal obstruction. It can cause pancreatic and biliary tract disease because it causes the lining of the ducts that drain these organs to the bowel to help digest the food grow and potentially cause biliary tract disease and pancreatic disease. Because you're absorbing better, you can have fluid overloaded in individuals who've gone into congestive heart failure as a result of this medication. It can also increase the absorption of some medications. So if you're on a blood thinner, or if you're on pain medicine or narcotic, and if you absorb more of this drug, you may have super therapeutic concentrations in your blood and have adverse effects of that. So that's got to be watched when you're dispensing this medicine. And I've listed here some of the side effects associated with the medication. As you can see, there's some digestive symptoms that happen commonly, and this isn't terribly unexpected because it's a growth factor that affects the bowel, and the bowel's working harder. So the current indications for prescribing this medication is adults with short bowel on parenteral support. It is not restricted to individuals who are on this for 12 or more months. You can have this medication dispensed if appropriate if you're on parenteral support for a shorter length of time. Those who prescribe this medication must pass an online course. The FDA has restricted the number of companies that the medicine can be dispensed through so that they can keep track of side effects. And the FDA also asked the company to set up a short bowel syndrome registry, which is considered a research project, so it's voluntary. And they're looking at all patients with short bowel syndrome on or off drug so that we can compare those who are getting the drug to those who just have short bowel syndrome, generally speaking, and to make sure that there aren't more problems in patients who are on this drug. Finally, the drug is very, very costly, over $300,000 per year, and so the company provides case management support to help with payment of the drug. They work with insurance companies and then orphan drug funds to help pay for the medication. So in summary, for the medications that I've covered today, I'm just leaving you with this list to just help organize what I've discussed to this point and to clearly illustrate when we use these, what indications we use these medications for, and which ones are off-label. Next, I'd like to finish up by briefly talking about surgical management of patients with short bowel syndrome. Autologous GI reconstruction refers to putting existing bowel that is out of circuit back into continuity. So if you have surgical resection and potential bypass with some remaining bowel, or if you get on parenteral nutrition following a gastric bypass surgery for obesity, we would consider putting bowel back into continuity to increase the amount of absorptive surface area and decrease the need for parenteral support. So this is what's done most commonly and can be done at many centers with an experienced surgeon. Another surgical procedure that's done relatively commonly is called strictureplasty, often done in individuals with inflammatory bowel disease who've had resection in the past, and they've got active disease, as is illustrated in A of that figure that I show you. And so that narrowing is interfering with digestive function. And even though there's active inflammation, if you cut the bowel lengthwise and then sew it up perpendicular to that incision, you open up the bowel, you alleviate the obstruction, and interestingly, with the better flow of intestinal contents, the inflammation there tends to stay relatively inactive. So this is a way that surgeons can maintain bowel length, relieve obstruction without resecting more bowel and potentially resulting in short bowel syndrome. These last group of surgeries that I'll mention that fall into the realm of autologous reconstruction, one group, this valve and reverse segment that I show you here, is to slow down the transit of the intestinal content through the GI tract. There are 3 other procedures that are done in individuals who have adaptation where the bowel dilates for long segments and it becomes less functional because the dilated bowel has poor motility. And so there are these 3 procedures. Here's what's termed plication, which takes dilated bowel and just narrows it down a little bit. This longitudinal intestinal lengthening and tailoring procedure, also referred to as the Bianchi procedure, again for dilated bowel. And then finally a technique called serial transverse enteroplasty, where you take a stapling device that's used by the surgeons and you go in a zigzag fashion to narrow the bowel. These are done in individuals most often in the pediatric population where their bowel adapts and tends to dilate more than adults to help diminish their reliance on parenteral support. These surgeries that I show in this slide are done at are considered at specialized centers where they have expertise and they're doing enough of these procedures to do them well. Finally, a word on intestinal transplant. This cartoon shows the 3 major types: small intestine, liver and small intestine, and then what's referred to as multivisceral. So in addition to the liver and the small bowel, you can see that the pancreas and the stomach are replaced. The indications for transplantation have been recently extensively discussed in this publication from the European Society for Parenteral and Enteral Nutrition on the care of chronic intestinal failure. Most commonly, it's when an individual fails the use of home parenteral nutrition. This is also the approved indication by the Centers for Medicare and Medicaid Services. I've listed them here for you. The one that is one within this category that one would consider listing somebody for transplant with is someone with impending or overt liver failure. Bilirubin's going quite high, 3 to 6 milligrams per deciliter, or where somebody has cirrhosis and the complications of cirrhosis. So these are some indications for intestinal transplant. There's 2 other instances where there's high risk of death and high morbidity associated with short bowel syndrome, where one might consider doing transplant. And within this list, there's a specific condition that is an invasive intra-abdominal desmoid tumors that occurs in individuals with familial adenomatous polyposis syndrome, where resecting these desmoids and doing intestinal transplant can be curative for them. So you can see these 2 items that indications that I've listed in red is where transplant centers would list an individual. for. This final slide shows how often intestinal transplant is being performed. You can see that the volume in adults and children have dipped off over the last decade. This is presumably due to improvement in our ability to interact with intestinal rehabilitation in patients. Also, there's as with many other conditions for which transplant's done, there's generally overall an organ shortage for these individuals. Finally, you can see graft survival is just fair, with roughly 50% 5-year survival of the graft in patients who undergo this therapy. And this was all reported in a recent review of intestinal transplant. So currently, with these relatively low rates of graft survival and improved 5 years and better 5-year survival on parenteral nutrition, ranging anywhere from 60 to 80%, long-term parenteral nutrition is preferred. So in closing, I've got this figure, a triangle or pyramid, showing that, as Laura said, diet is the foundation of taking care of individuals with short bowel syndrome, that there's interventions with surgery and medication that can also help. And I've got the patient listed here at the top of the pyramid in red, that all care needs to be patient-centered. As Laura's mentioned, all patients are different enough that they have to be managed on an individual basis. Thank you for your attention, and I guess we're going to move to take questions.
Yes, thank you, Doug. That was wonderful. In case none of you have been looking at your time, we are getting a little short here. So what I want to mention first is that we have many more questions than we could possibly answer today. And questions that we don't get to, we will post on the Oley website with answers. And that's going to be on the webinar page, which is oley.org/webinars. But we'll go right now and see how many we can answer. The first question asks, what are the specific issues a person without an ileum would have, and how would you suggest addressing them? Dr. Matteries, if you want to try that first.
Sure. I think the biggest issue for somebody that does not have an ileum is vitamin B12, because that is the portion of the bowel where vitamin B12 is absorbed. So if your ileum has been removed, you will have to have vitamin B12 injections, generally once a month. And Dr. Steiner, do you want to talk about the medical aspects of that?
I agree strongly. B12 should be started, especially if someone's had 3 or more feet of their ileum resected or have extensive disease of that segment of the ileum. And then it just depends on whether the small bowels connected to the colon, that type 2 anatomy that you showed in your presentation, or whether it's an jejunum, and then the diet's the foundation. So that's the key thing. And we talked about bile acids. If the ileum's completely removed, generally speaking, I don't think you should be on a bile acid binding resin.
Okay. The next question relates to hydration. Is there any trick to keeping yourself hydrated? I've been in the hospital numerous times for dehydration. The hospital staff says to always have a glass of water beside you, but this doesn't always help. What do you suggest, Dr. Matteries?
Water is really the wrong thing to take. Water is hypoosmolar, and that will, if you drink lots of water, you'll probably notice that you have more ostomy output or more diarrhea if your colon is in circuit. The key is to try and drink some of these oral rehydration solutions that I listed on that one slide, and to sip them very slowly. Do not gulp these fluids. There are other tricks you can do, like you can put some of these oral rehydration solutions in ice cube trays and freeze them, and then it's almost like a slushy. And consume them again very slowly and in small amounts. There are some people who simply will not be able to maintain adequate hydration by mouth and will or may require additional maintenance IV fluids. Sometimes that's done at night or intermittently throughout the day. And sometimes patients, if you have a PEG tube in place, for example, oral rehydration solutions can be infused through that PEG tube at night while you sleep. But the key is not to drink hypotonic fluids such as water or hypertonic fluids such as soda pop, sweet tea here in the South, and things like that, and to sip them very slowly.
I would add to that, I agree completely. I would add that everyone should recall that we haven't mentioned that, the digestive secretions amount to close to 7 liters of fluid, and so if you eat and drink, you're stimulating that process. And occasionally, if you have really high output, I will ask patients to limit their intake, sometimes to less than 2 liters a day, occasionally being even a little more strict than that. And to remember that if you are home and start to feel dehydrated, you shouldn't drink more because you may get more dehydrated. You should actually take extra IV fluid.
Okay. I think we've run out of time for the questions, and I apologize for that. This is such a wonderful presentation, and I'm going to repeat that we will, the rest of the questions that we didn't get to today, and there are a number of them, that we will be posting the questions as well as the answers on the website shortly, as well as a recording of this webinar. The slide that should be showing now shows the 2 main pages on the Oley website that have resources that are related to short bowel syndrome, as well as the dehydration and diarrhea resources in case you want to go back to those. The handouts from this presentation will also be available on the website in the next few days. I need to bring this presentation to a close. Thank you, Dr. Seidner and Dr. Matarese, for an excellent presentation. We appreciate you sharing your expertise. We also want to thank Shire for supporting this important educational program. And thank you to the participants for joining us. And do check the Oley website for our next webinar or any future webinars. We also have recordings from past webinars up there. Again, that address is oley.org/webinars. And thank you again for joining us. Bye-bye.